All right. Thanks for joining us or joining me. My name is Jessica Reeves, and I am the world's most productive nurse practitioner. Little prop right there. That's always fun. I'm so glad that you're here and that we're talking about different things related to time management and charting. It's one of these weird things about medicine, really, not just being a nurse practitioner or being a physician associate or whatever your role is in the like healthcare ecosystem. But time management and charting is something, charting specifically, is something that affects every single one of us, right? You cannot do this job without charting. It doesn't matter where you work, what your setting is, what your educational background is, where you went to school, how long you went, all that stuff. We all have to chart. And it is something that we aren't taught how to do effectively. We might have learned in school how to write a SOAP note, and charting is more than a SOAP note, right? SOAP note is a good way to start, um, but it's not really what you do with a SOAP note in school is not the same as what you do for charting, right? In the real world. So that is almost a disservice. When you're writing that SOAP note in school, that's something that teaches you how to demonstrate your knowledge and that you understand the different differentials that may be at play or um, the pathophysiology or the pharmacology or all of the above and more. When I was in school, we had to write SOAP notes and cite, academic sources and all that, which is great as a student. But these were things that when the assignment was done and you did everything in the rubric, ended up being 7 pages long, right? So if that is all that we learned, then of course, when we get into practice, our charting is going to be really lengthy. Okay. So I'm on like a mission to make it so that we know what we're doing when it comes to charting, that we kind of peel back some of the layers and see what's really going on. Why are we spending so much of our time charting? And what can we do about it? So we'll talk every Tuesday at like 1 o'clock about what we can do. If you have questions, definitely you can post them in the group. You can send them to me directly, and you can, if you'd like to include your name, great. If you'd like to come up and talk and get coached in part of the group, we can do that as well for this first one. I think people want to kind of see how things go and what to expect. So that's totally fine. And I do have some questions and some other things to talk about. But I just want to give you a little bit of background, right? And sort of setting the ground rules. So, as I said, my name is Jessica Reeves, and I call myself the world's most productive nurse practitioner, which is kind of a joke because I think having a sense of humor is a big, big, important thing in our work and in our profession. Not a requirement, but almost kind of should be. But I find humor to be very useful. So that's where that title comes from. Having worked in really, really busy practices, so I've worked in reproductive health, family medicine, where, I'm seeing patients every 10 minutes. That is a crazy schedule, right? So if you're seeing a patient every 10 minutes, then you're seeing 6 patients an hour, which is, and the schedule always full, right? So I learned like what to do and what not to do to stay on time, to get my notes done, and to get out on time. And one day I was sitting down, here's my little backstory. Really, one of my proudest professional achievements. I was sitting at my computer. I actually had a couple minutes left. I was killing some time, like waiting for a patient or something. And I realized that we used Epic, and in Epic, there was a report generating option. And you could there's a bunch of different reports, but the only one I remember that I did was one that had it's about productivity or user efficiency or something. It had some name like that, and it said it had a few different things. One of the criteria was percentage of charts closed within 24 hours, so like same day, and it had everybody in the practice, and this practice had like around 40 providers. And mine, went back 4 quarters. So I had the previous 4 quarters. Mine was 97 to 100% same day. And I wouldn't have guessed that if I didn't run that report. I knew I was pretty good at, running on time and getting my things done. I didn't know I was that good, right? So I didn't know I had like superpower kind of stuff going on. So I realized, oh wow, okay, maybe there is something here. Maybe I am doing something differently than other people, or I've got like a different perspective or something. So I decided to kind of explore that some more. And the book came as part of the coaching is a part of that as well. Um, I had always received good feedback from my peers about my ability to manage my time, and I just thought they were being nice. And I thought maybe they struggled a little more, and so of course they're complimenting me, but there's something to it. Um, that's kind of where all of that came from, and it's important to me in my professional life and life, to feel like I have something to show for my time. So at the end of a day, a week, a year, I want to be productive. So that was my joke there. That's where the title of the book came from. And I just love to spread the message. I love to talk to um, clinicians really of any sort because the messages are pretty universal and they are relevant for so many different disciplines. I usually speak to nurse practitioners only because that's my background, that's my training. But I actually have worked with an oral surgeon who is experiencing all of these same things. And I never would have thought of people in the dental field as potential time management, like people who could benefit from more time management skills, or charting efficiency, that sort of thing. So that was a really big surprise. But there's been so many big surprises with this. So I love to talk with people. It really energizes me to problem solve, to talk with people, and to do what I can to, oh, we got some more coming on in, to do what I can to, hello and welcome for those just joining us, to do what I can to help folks with their time management challenges. So I do have a question that was sent in, which I think is a great question because I think so many of us have been in the same boat. And I think we can all benefit from it, right? So either we've been there, we are there, or we have like some thoughts about what we could do differently based on what other people are experiencing. So the question that I have is the person who chooses to remain anonymous, which is completely fine, um, but could be anybody really, right? My MA takes more than 15 minutes to room patients. I work in a private primary care practice. What do I do about this? This is a great question. What I love about this question is that's one of the things that role transition from RN to NP is tricky. And there's a lot of guidance that we need, I think, right? When you're an RN, you show up for the day and you kind of respond, react to whatever's going on in your day. And you work your like maybe 12 hours if you're working inpatient or whatever, you kind of clock in, do your work, whatever happens, you just take it as it comes, and then you clock out at the end of the day. 12 hours later, which is really like 13 plus. But when you're an NP and you tend to work in these outpatient settings, you're in this different scenario than you might be used to. You have these people that you have to sort of manage, but that you're not their boss. You have like no actual authority over them, but the way they do what they do, or that they don't, or where they have room for improvement, has so much capacity to impact your day and to throw you off or to make your day better. And it's really, really tough. So there's a concept of influence without authority. And that's something that sort of comes into play with this. I have definitely experienced the same thing where I'm ready to go. I'm literally waiting outside the door for the MA to come out and give me a little handoff report and tell me, okay, here's what they're in for. Here's what's going on. The appointment was really booked for a follow-up of their hypertension, but they've got this weird rash and okay, curveball happens all the time. But you're wondering like, what is taking so long? So I find for me, my guideline is about 10 minutes is in a typical situation for a typical patient, not a new patient, not somebody who's new to the practice, not somebody who hasn't been seen in 5 years, but like if it's your typical primary care outpatient situation, it should take about 10 minutes to room them. If you have some slightly different presenting issues, right? Then it could take a little bit longer. So if this is somebody who, we think that it's a UTI or we need to get a urine sample for them and they don't ambulate very well, or they have trouble producing a urine sample because they just went just before they came to see you, which also happens all the time. Those times can take a little bit longer. So you have to give a little bit of like leeway for that stuff. But in general, 10 minutes should be enough to room a patient. So you have to get to like a root cause, right? So if this is 15 minutes, first of all, is this actually 15 minutes? Like, does it feel like it's always 15? I would write it down. I would go for like a day and write down as much as possible. You're going to miss some, right? You're going to get busy with other things, but really try to get that objective data. Patient arrived such and such a time, was ready to see me at such and such a time, and do that for a day or maybe 2 days. And when you've got that objective data, now you've got something that you can actually dig into. Sometimes it feels like it's happening differently than it actually is. It feels like it's 15 minutes and it's not always 15 minutes. Maybe it's 15 minutes that you are the ones that you're aware of because those are the ones you're ready for. And maybe there are other times that it's 5 minutes, but you were running late and so you didn't know. So that's one of the first things is to challenge the assumption. Is this actually 15 minutes every time consistently? Let's assume it is. Okay, let's assume yes, this writer who has this question has done this. And yes, it is consistently 15 minutes every single patient. That would drive me crazy. But now what we need to do is look at the why. So look kind of upstream and see what could be causing this. Is this every patient or is it just certain patients, right? Is it patients that are older, patients that are younger? If you're in a family practice setting, so you see kids, those might take a little bit longer than like a healthy 30-year-old patient. But looking to see what could be the reason for this. Once you have enough information to know that you have something to actually dig into, then what I would do, I like to assume the best, prepare for the worst, but assume the best. There could be a good reason, but I don't know what it is. So talk to the person. You and the MA or whoever is rooming your patients for you should be a team, right? Ideally, you're a team in service of the patient and a team with the patient in service of the patient's health. But you and the other staff are teamed up to serve the patient. And if one of you is struggling, maybe there's something the other one can do, right? And maybe sometimes even just pointing it out is enough. So I would say bring them in or get the data, talk to them. I noticed that for the last couple of days, I kind of was like keeping a little bit of track of it. And I noticed that it seems like you're running closer to 15 minutes. And I don't know if you know, 10 is what I've kind of budgeted for. That's the time allowance that I have. That might be all it takes. That would be great. If that isn't all that it takes, then you need to dig a little deeper. I like to do, there's a management technique, and it's a way to get to like a root cause analysis. Ask why 5 times. So, and not, you don't literally have to say why, but why? Why? So, why are we running late? Oh, because, all of these patients are coming in and they're all pediatric patients and they bring, it's only one kid that the visit is for, but they bring the other 3 with them. And so it's chaos in there. Well, that would definitely make me run late. Maybe we need to adjust our expectations, right? Then you ask why again. Why are they bringing all the kids? Could we do something different with that? Oh, they have childcare issues and all of the kids are preschool or whatever. Or the kid that was brought in for the visit is the one that's in school and the other ones aren't. And the mom, this is the best she could do. Okay. Again, we have to adjust our expectations. That can't be every single patient though, right? And then you just keep asking why. So why? Oh, because this was, all these patients are older and have trouble ambulating. Okay. All these patients have difficulty hearing. There's so many different reasons. Or maybe there isn't a reason. Maybe when you bring this to the attention of the MA, they don't know why. Maybe then you have to kind of like give them an opportunity to think about it, to reflect on their own practice. Don't necessarily assume the worst. That's easy to do. It's easy, easy, easy to do that and have that knee-jerk reaction and be like, oh, they don't care. They don't know how stressful my job is. Could be, but there are other things that it could be as well. So asking them and involve them in the solution. Is there something I could do that might make it a little easier for you to do this? Because I believe, and there are exceptions to every rule, people don't necessarily want to do a bad job. They don't want to have a bad experience at work, even if it's just that's the baseline, that they don't want to be like having work be a drag. Anything they can do to avoid that is something that they are going to do. It could be as simple as that. So involve them in the solution and hold them to account as well, right? So it's like, oh, okay, maybe you're having trouble doing med reconciliation because you're not really familiar with what a lot of these medications are. Maybe they're working in a new setting. They came from cardiology and this is now family practice and they don't know what all these diabetic medications are and everybody's on them, that sort of thing. So we can easily fix that. I can help you learn that. I can put a list together. We could do checklists. There's so many different ways that we can go about that, but involve them in the solution. Don't make assumptions, ask them. And if that doesn't work, if you find out your objective information and oh yeah, no, they're running late all the time, and you ask them, hey, what could it be? Is there something I can help with? They have no clue. They're not interested in solving it. They're just gonna let it happen. Okay. Then the next thing is then you have to bump it up the chain of command. So whoever is their boss, you have to let them know how this is impacting the flow, how this is impacting patient care, your ability to deliver patient care. It doesn't mean they'll care. It might matter zip to them, but involving them in the solution as well, because now you know you have done your best. When you're able to bring some objective data to them, again, not a guarantee, but it can stack the deck in your favor in terms of getting closer to a solution, right? If you've had that information, you've been tracking it over time, this is very objective. This is not like me with a vendetta against that staff member or anything like that. This is really just about getting through the day efficiently. That's all it is. It's not charged. That also allows you to be a role model because you never know. I wasn't always a nurse practitioner. I was an EKG tech once upon a time. I was a secretary once upon a time. Having those role models who kind of showed me like what I want to do or what I don't want to do was really powerful. And I think about a lot of them actually pretty frequently. So think about which way you'd like to be. Would you like to be that role model for the staff, for all staff, as well as maybe like rooming staff, MAs that you're working with? Because someday maybe they will become a nurse practitioner like you and they will know how to navigate these conversations. Okay. So if anybody else has any other questions that you want to throw in, feel free to add it to the chat. But I have something else that I just want to talk about to kind of round out our time. And it really is a big part of your time management, right? Because charting is such a big piece of what we do, we tend to look at like the note itself, right? It's all about the note. And if I'm having a problem, it's because of my note, and I just need to do them differently, faster, better, whatever. But it's the note. We kind of blame the note, right? That makes sense. I mean, I kind of see that. But I really think that when we peel it back a little further and we look at these upstream factors, the note is the output. Is that where the problem started? If we are spending that like extra 5 hours a week, whether it's nights, weekends, whatever, working beyond our regular hours, is that just because of the notes? Think about your experience, right? I think I like to look upstream. And one of my big pieces of advice is a focused visit. So when you have a focused visit, you can have a focused note. The flip side is also true. And you have a visit that just goes all over the place. Well, of course, your note is going to go all over the place too, right? And you're going to be stressed when the time comes to write that note. It is going to take you longer because you're going to have more that you need to document, right? So there are always exceptions. There are times when you've got that patient who maybe has not been seen by any provider in like 10 years, and you know they're not going to come back. You got to get everything you can possibly get. We'll be lucky if we see them again in 12 months, right? Those are rare. That should not be every patient every day. For the average situation in a primary care, family practice setting, even urgent care, really, in certain settings, I really recommend a focused visit. And the way that, like the framework that I look at for this is it's on average, it's about 10 minutes to fully assess and explore and make at least an initial plan for any issue. So whether it is new onset hypertension, a rash, vaginal discharge, any of these things, or all of these things, right? We've all had that experience where the patients come in and they've got 10 things they want to talk about, but we only have a 15-minute visit. I've talked with a lot of nurse practitioners and physician associates over time, and in a primary care setting, visits average between 15 and 30 minutes for like a follow-up or a sick visit. So new patients sometimes longer in very forgiving settings, but 15 to 30 minutes is usually how much time you have. So if you're on that 15 side of things, you're going to get to like one thing well, maybe two. But if a patient comes in with five different things, they're going to need to come back. We're going to have to pick today's two, and then the other three, have you come back in a week or whenever we can get you back in, maybe the next day. If you have a 30-minute visit, you could cover three things, right? You could really kind of get a good handle on three different things in 30 minutes. If you have five things and you let the patient, you're like, well, I got 30 minutes. I'm going to let them keep going. And they just keep adding that one more thing, one more thing, one more thing. And say you have five things that end up getting put into that visit. When you cover that much in that amount of time, it really dilutes the visit, right? It is really diluting the visit or it's making you run late. Are either of those really like an option for you? Do you feel good about that? Is that great patient care? If you run late, aren't you taking time away from the next patient? Or if you then feel bad about running late, you don't take time from the next patient and then you just keep paying it forward, this debt, and then you're working late. So then you're taking time from yourself or your family or your friends. Is that okay? I don't think it should be. That's a decision that you have to make for yourself, though. So the more you're covering in the visit, the longer your note's going to be, and then the longer it's going to take to write that note, right? And if you cover too much in too small of a container of time, then you're diluting it, right? And it's overwhelming. It's overwhelming for the patient, really. They might not think of it that way, but it's overwhelming for the patient to go through all this stuff and to remember when this started and how many times they felt that and what they did to treat that. To try to cram that all in a small period of time can be overwhelming. And then it's overwhelming for you to chart. And then when you finish the charting, you sign the note, it's locked, it's done. Somebody else is going to need to refer to that note. Maybe you send them for physical therapy and because their shoulder hurts. So then physical therapy has to dig through this whole long note to get to the part about the shoulder, right? And all this other stuff that has nothing to do with them, has nothing to do with the shoulder. So it's overwhelming for them as well. So it's creating more work for everybody who has to be a part of this equation. It's a hard thing to do, and it's a hard thing to get used to doing, but it's a great skill once you do. And that is being in the driver's seat and sometimes saying no. You could say it in a nice way. So you could say, hey, Mrs. Smith, we only have time to get through two things well today. So what would be your top two? Or what is everything? Give me the list of everything that you want to talk about, and then we'll kind of agree what the top two are for today, and then we'll have you come back for the others because her priority might not really be the most clinically significant priority. But you need to maybe be the one to say, I'm going to need to have you come back for that. It feels weird. It feels super foreign. It feels like something we shouldn't do. And I guess I would say, like, where does that feeling come from? If that's how you're feeling, right? Is it you? Is it like self-talk? Or is it your boss? Is it your colleagues? Is it the patient? Is it the whole system? is that we just don't want to do anything wrong. So we just are so afraid to do something wrong. It makes it like piss somebody off that we just say yes to everything at our own expense. You could do that sometimes, but is that sustainable in the long term? No. It could really be a recipe for burnout. And do you want that? I don't think so. You spent way too much time, too much money, too many missed family events and friend events and missed movies and you name it to get to this point just to become burnt out, right? So we have to get like more comfortable being in the driver's seat. We have to protect our time because if we don't, nobody's going to do that for us. And sometimes we have to find a way to let the patient down easy, to have them to make that plan for a follow-up for another visit to come back and get to the rest of these things because we do. We want to know. We want to know everything that's going on. We want to come up with the best plan for the patient. We want to do a good job. That's something that's so awesome about us. But we also have to balance that with the reality. If you have a 15-minute visit, you can get through one, maybe two things. If you have a 30-minute visit, you can do like three. But when patients come in with these really long lists, those two don't go together. I had a colleague once that I am not kidding, had a patient with 19 different things, literally 19, because she told me the next day. And it was the last patient of the day, so it's like a 4:30 visit. And I left for the day. She was running late from the patients before, and it was like 5 of 5 by the time she went in there, even though it was a 4:30 visit. And I saw her go in. All right, see you tomorrow. And I left. And I went home and I realized, oh no, I had to go to the pharmacy, which happened to be in our same building. So I had to get something at the pharmacy. Okay, I'll pick up a prescription or whatever. So I go back to the same building, not back to work, but this is the same building. And I go in to the lobby to the pharmacy. And I saw that same patient who was a little noisy, distinct. I knew it was her um, leaving, walking through the lobby. And I looked at literally, I remember looking at my watch and I was like, oh my God, it's fucking 6 o'clock. And she is just leaving. So the next day I go to work and I didn't even have to ask. This colleague told me. And she was like, you would not believe that patient. Oh man. And this patient had not been like out of care for a long time either, like maybe a little while, but not, not drastically long. 19 different things. All right. Well, if you follow my rule of thumb, 10 minutes per issue, that would be 19 times 10, 190 minutes. That's over 3 hours. She didn't take that long. It wasn't actually 3 hours. But then how long is it taking her to document? She probably was writing that chart note until 10 o'clock that night. Like, no kidding. Because she would, and then she would go into great detail also. Then, if you've got 19 different things, are you really getting to the bottom of all 19? No. And if you're getting 19 different things, you're going to have some wild cards that are going to come up as part of 19, right? You're going to have, oh man, she's going to need a referral to this, 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 and we need this, this, this lab. And then those labs are going to come back. You're going to have something that's going to be a total curveball, big surprise. It just creates so many issues. It's okay to pump the brakes, to look for the most urgent things to triage. Look for those most urgent things first. Focus on those. If you've got a 19er and have them come back for like the other 16, right? Or to say, let's plan to see each other like once a week for the next few weeks, right? Until we run out of things to talk about. We need to be able to do that. And we need to feel comfortable doing that because these 19 issue patients should be a unicorn, but they're not. If you haven't had that experience yourself, then you've probably seen somebody else. Like I saw the colleague that had that experience. So these are not things that you hear about in the urban legends. These are things that are actually happening. And they're happening kind of frequently. Why is that? Right? I encourage you to think about that. I think we are just about wrapped up for time for today. I'm so excited to be doing this for you each week. I'm totally not kidding. I love to talk about this stuff. So please, between now and next Tuesday, we'll be back at it, right? But between now and next Tuesday, if you have questions that come up, feel free to send me a message. You can post in the group. We can talk in the group. We can talk through and get some, free coaching as part of this as well. Everything is, just between us. just so that we can get the support that we need in a way that makes us feel better about ourselves as professionals and not worse, right? So thank you very much. This is Jessica. It's been great to spend this time with you, and I look forward to doing it again next week. Take care.